everyone to our last international rounds of the academic year. So we will be stopping for the summer with these rounds. So it's my great pleasure to introduce Dr. Giovanni Di Salvo, who you cannot see because his camera doesn't work, but Giovanni is a friend. We work together in the Bronton. Giovanni is a pediatric cardiologist and is currently working in Padova, as the chair of the pediatric cardiology unit in Padova. And he's an expert in echocardiography, and he's going to talk today about advanced echocardiography in congenital heart disease. So, Giovanni, thank you for joining us, and the floor is yours.
Thank you very much, Rafa. It's a great pleasure for me to be with you today. And so in the next few minutes, I will present you our experience with advanced echocardiography in congenital heart disease. So, we know that congenital heart disease patients are an heterogeneous group of patients with a very large spectrum of anatomic substrates, even within the same lesion. So, considering different kind of surgeries, different kind of percutaneous procedures, each patient is unique. On top of this population is getting older. And so to the congenital problem, we add up also the acquired heart disease problem. And this will require further cardiac evaluation. So nowadays we talk a lot about multimodality imaging, and the guiding principle in this regard is to find the right tests for the right patient at the right time. And in this regards, the imaging specialist has a key role in defining the most appropriate diagnostic strategy for that unique patient, for that particular clinical question. In 2018, with the European Association of Cardiovascular Imaging, we produced a position paper about how to image the adult patient with congenital heart disease. And as confirmed also by this position paper, echocardiography is the first line imaging modality in assessment and in follow-up of ACHD patients. I would say that echocardiography is the core of the diagnostic evaluation of ACHD patients. But as you can see from this table, it's not only general echocardiography that is recommended, it's also the application of advanced echo modalities like Speckle tracking or 3D echocardiography. Of course, 2D echocardiography is the foundation for anatomic and physiological assessment. 2D echocardiography is the technique with the highest temporal resolution of all the imaging modalities, and is the best image modality we have to assess valvular leaflets. It provides real-time assessment of anatomy, physiology, and function, and adding multiple sweeps to the different windows, we can better understand 3D anatomy, even using 2D echocardiography. This table and those two clips, just to remind you that 2D echocardiography is the technique that we have with the highest temporal resolution. In this clip, you can see above there is a CMR and below there is an echo. Patient is the same, but on the CMR, you will see that we cannot catch the anterior motion of the subvalvular apparatus, which is quite obvious on the 2D grayscale images by using ultrasound. This is due by the fact that echocardiography is the technique with the highest frame rate. And also, echocardiography has a very good spatial resolution. The problem with the echo is the contrast resolution. And we need to know this physical principle in order to use the better technique we can for our patients. And echocardiography in CHD patient, as we know, is based on structures rather than views. We have to focus more on structure. And there is a tremendous amount of anatomic variability in CHD. So the views are just a starting point, and we need to adapt these views to that particular anatomy, once again, to that unique patients. It's very important to use sweeps and longer clip in order to better define the anatomy. 3D echocardiography provides in-phase visualization of cardiac valves, which are very easily interpreted by surgeons, and this helps a lot in discussing patient and to take decision once we have a clear picture of the patient. 3D echocardiography is particularly helpful to give us details in terms of complex anatomy, especially when we want to understand the relationship with neighbor structures. And also by 3D echocardiography, the measurement of LV and RV volumes and ejection fraction are preferred over 2D calculation. Particularly, ejection fraction by 3D correlates very, very well with CMR, which is considered the gold standard for volumes. But again, when we move to 3D echocardiography, we have to keep in mind some tips for the acquisition. First of all, we need to have very good 2D image quality. If the 2D image quality is not good, 3D echocardiography is not going to help us. And we need high frequency transducer, so that's why we need to push companies to provide us better 3D probes in order to obtain the highest frequency we can. We need to use narrow sector, and we need to remember that 3D echocardiography has an anisotropic resolution. It means that we can have a good spatial resolution on the axial plane, but we lose something on the lateral plane, and we further lose something on the elevational plane. And just as a suggestion, before acquiring data, it's always better to review the multiplanar images in order to be sure that all the information that we are looking for are there on the 2D multiplanar images. Otherwise, we save a huge amount of data and we use a lot of space in our computer and we don't get the information that we want. So this is just a clinical example of the help that 3D echocardiography can provide us. This is a patient with the Fontan circulation, and as you can see, the left AV valve has a significant regurgitation, very eccentric jet hitting the roof of the atrium. On 3D echocardiography, we demonstrated that this left AV valve is a trifoliate left AV valve. This is the view from the ventricle, and this is the view from the atrium. So you can see that the valve is trifoliate. This is important because at the moment of Fontan, this left AV valve regurgitation was considered to be mild, and so was not addressed. But perhaps if we knew that the left AV valve is trifoliate, so there is a cleft, probably, and we know that cleft can only get worse, and then once we get regurgitation from the cleft, we can get also other regurgitation from the coaptation point. Probably we should have addressed this valve at the time of Fontan. While now we need to go back to surgery because of this significant regurgitation. This is another case we published a few years ago while I was at the Brompton. This is a patient with Epstein disease who underwent cone repair. As you can see, the cone was not so successful. There was a huge periannular leakage and significant regurgitation from the repaired valve. We performed a percutaneous closure with a device of this periannular leakage, and we also saw that the device pushed the leaflets of the reconstructed tricuspid valve after cone together, and so we obtained a very good results by using this percutaneous approach. But 3D echocardiography is helpful not only for morphology, for details in terms of morphology, but also because it provides us a lot of information in terms of volumes. We know that the volumes obtained by 3D echocardiography for both left and right ventricle are much more reproducible and are better correlate with CMR. Particularly, left ventricle volumes are very well correlated with the CMR. On the other side, right ventricular volumes are less well correlated, and anyway, echocardiography always underestimates volumes when compared with CMR. So 3D echocardiographically obtained RV volumes are well correlated, but typically underestimate volumes compared to CMR. But the question we should ask ourselves, if by 3D echo we should chase CMR, or should we live on our normal values? I mean, it's important to be reproducible, most of all, to have our normal values and follow our patients on our values and see if there is a significant increase over time. So the importance is the factor that is extremely important is reproducibility. 3D echocardiography can also be used in virtual reality, so we can navigate the 3D datasets. We may think that this is the future, but in reality, this is already the past, because we nowadays have second generation virtual reality glasses, which are lighter, which do not require computers, do not require room sensors, no need of cables, and can be multi-user, and controls can be obtained just by eye movement or the movement of our head. And also nowadays we have possibility of 3D monitors with holographic display. There is some background noise. Maybe someone has the... Yes, please, thank you. And of course, we can also superimpose virtual reality on 3D models to better try to understand the interaction of different structure and the morphology. But of course, the assessment of our patient morphology is important, but we need also to assess function. And we know that cardiac mechanics is rather complex. It's much more complex than ejection fraction. We all talk about ejection fraction is a very convenient parameters. Everybody knows about ejection fraction. It's very easily understandable parameters, also across different specialties, but probably won't tell the whole story. Cardiac mechanics, indeed, is rather complex and is based on longitudinal shortening of the left ventricle, based on the contraction of subendocardial fibers, and also circumferential shortening due to the contraction of the mid-layers fibers of the left ventricle, and then the radial thickening of the left ventricle. Not only that, we have also the rotation of the base and the apex of the left ventricle, with the base that during systole rotates clockwise, while the apex during systole rotates counterclockwise. By echo, we can use myocardial deformation imaging. In contrast to the other conventional measures of ventricular function that all require geometrical assumption and, for instance, ejection fraction is based on volumetric data, myocardial deformation imaging provides just information from the direct interrogation of myocardium. And with this technique, we can assess longitudinal function, circumferential function, radial function, but we can also assess rotation and torsion of the left ventricle. In the recommendation of the American Society of Echocardiography and the European Society of Cardiovascular Imaging, global longitudinal strain is recommended. This is for the adult patient, but the same recommendation we can see also in the ECVI position paper for imaging the adult congenital patient, where 2D speckle tracking derived LVGLS is considered in the evaluation of our patient together with 2D speckle tracking for the right ventricle. With this technique, indeed, we can study function of different myocardial fibers. We know that if we take a piece of myocardium, we have fibers oriented in a different way. In the subendocardium, we have longitudinally oriented fibers. Then in the mid-myocardium, we have circumferentially oriented fibers, and in the subepicardium, we have oblique fibers. Subendocardial fibers, while contracting, will be the main responsible of the longitudinal shortening of the left ventricle during systole, while mid-myocardial fibers will be responsible of, again, of the circumferential shortening of the left ventricle, while subepicardial fibers, oblique fibers, will be one of the major determinants of the radial function. Why all these things may be relevant? Because longitudinal dysfunction happens before ejection fraction drops. As we can see in this graph, normally we have a normal ejection fraction, then we have a drop in longitudinal deformation. This happens on a parallel way with diastolic abnormalities. But at this level, ejection fraction will stay normal. This is because of compensation from circumferential fibers. With this understanding of cardiac mechanics, we now know that what we have been taught in the past, that diastolic dysfunction always anticipate, always precede systolic dysfunction, maybe is not completely true, but was what we could detect with the technique that were available at the time. Nowadays, with this technique, we can better study cardiac mechanics, we can better study longitudinal deformation, and we now know that longitudinal deformation impairs at an early stage when the ejection fraction is still normal. Strain imaging has been used in several clinical scenarios for congenital heart disease, and the main ability is to detect early subclinical left ventricular dysfunction while in presence of normal ejection fraction. This has been demonstrated in patients after a successful repair of aortic coarctation or after a successful repair for DTGA with arterial switch, or in Al-Kappa patients after repair, or in a symptomatic patient with valvular heart disease. And also, strain imaging, particularly global longitudinal strain, demonstrated a good predictive value in terms of outcome. But this is for global longitudinal strain. Recently, our group tried to use it not only longitudinal strain, but also to study the twist mechanics of the left ventricle in situations where sometimes it's difficult to get the right diagnosis. This is a study on patients with left ventricular non-compaction. We studied 23 left ventricular non-compaction young patients, and 24 young patients with left ventricular hypertrabeculation as classified by using CMR as gold standard, and 47 healthy young patients. What we found was that in patients with real left ventricular non-compaction, there was a reduction in the apical rotation and a reduction in the left ventricular twist. And this was able to better discriminate the real non-compaction patient from the ones with hypertrabeculated left ventricle. And this can be of help because many times in our practice, we may see patients with certain degree of hypertrabeculation, and we have to understand if it's real non-compaction or it's just an hypertrabeculation. In one case, we found that the twist mechanics and the apical rotation was impaired, but according to MRI, there was just an hypertrabeculation. However, this patient had a strong family history for cardiomyopathies. Another area where advanced echo modalities may be of help in the evaluation of young patients is the assessment of diastolic function. This is a very nice paper by Andrea Dragulescu a few years ago, where they assessed diastolic dysfunction in children. And they used all the parameters recommended by the guidelines at that time for diastolic dysfunction. They applied these parameters for diastolic dysfunction as recommended by the American Society of Echo and by the EACVI in children. And they studied children, normal children, children with dilated cardiomyopathy, children with hypertrophic cardiomyopathy, and children with restrictive cardiomyopathy. But unfortunately, the conclusion of the study were rather disappointing because the assessment of diastolic dysfunction in childhood is inadequate using current guidelines. Indeed, there is a large range of normal pediatric reference value that allows diagnosis of diastolic dysfunction only in a small proportion of patients. So the results of applying the guidelines of the adult patient in children, even with cardiomyopathy, were rather disappointing. And in many cases, using these guidelines, the authors were not able even to discriminate a patient with the cardiomyopathy from a normal children. In recent years, Speckle tracking has been used not only to study left ventricular deformation or right ventricular deformation, but also to study atrial deformation. And many authors demonstrated that the amount of atrial deformation during left ventricular systole, which is the reservoir function of the atria, is strongly correlated with left ventricular filling pressure as demonstrated in invasive studies. This is the correlation that was showed in this study, but there are another couple of studies confirming the same principle. Based on this data, the group by Roberto Lang used left atrial strain for categorization of LV diastolic dysfunction in adult patients. And while we know that using standard echo Doppler parameters, there is a gray zone, so-called pseudo-normality, here, in this paper, using the atrial deformation, they were able to see a progressive deterioration in atrial deformation from normal through grade 1, grade 2, and grade 3 diastolic dysfunction. So, according to this data, it seems that the use of atrial strain can be of help to simplify the evaluation of diastolic dysfunction in adult patients. Similarly, we performed the study in 136 young patients, 44 with dilated cardiomyopathy. All of them were below 18 years of age. 40 were hypertrophic cardiomyopathy patients, 7 with restrictive cardiomyopathy, and 45 controls. And we found, again, that using standard echo Doppler parameters, we were not able to discriminate controls from cardiomyopathy patients using E/A, deceleration time, or we could discriminate controls from cardiomyopathy patients using E/E prime, but we were not able to discriminate hypertrophic patients versus dilated cardiomyopathy patients versus restrictive cardiomyopathy patients. And the same applied to left atrial volume indexed for body surface area. On the contrary, similar to what demonstrated by Roberto Lang group, we found a progressive deterioration in atrial deformation from controls to restricted cardiomyopathy, going through dilated cardiomyopathy patient and hypertrophic cardiomyopathy patients. So it seems that this parameter could be of help, at least for a clear discrimination between controls and cardiomyopathy patient, and it seems also to be of help to better stratify in non-invasive way diastolic dysfunction in cardiomyopathy young patients. But strain has been used a lot also to assess right ventricular function. Those are the recommendation from the European Society how to perform echocardiography to assess right ventricular strain. And as you can see, they suggest to obtain a modified apical four-chamber view in order to better focus on the right ventricle, not to use the standard for apical four-chamber view. Personally, I have a problem with this recommendation because we know that although 2D strain does not have the same angle dependency of the Doppler-derived technique, there is still some angle dependence. So we should not be perpendicular. We should try to save the angle between our ultrasound beam and the right ventricle to keep this angle within 30 to 40 degrees. To use larger angles can impact on the value of strain. So I will be very cautious in using this approach, especially in patients. And again, the other point that I would like to highlight to your attention is, once again, both American Society and European Association recommendation papers strongly suggest to use two-dimensional derived strain to assess right ventricle, particularly RV free wall. And again, in this recommendation, this state-of-the-art review on RV strain was suggested once again to obtain an RV-focused view. And again, we have to keep in mind that there is some angle dependency of the 2D strain technique. And also, the authors encourage us to assess the RV free wall strain. However, I have some concern about that because the major mechanism contributing to RV pump function are different, of course, from those of the left ventricle, and they include contraction of the longitudinal fibers, which shortens the RV along the long axis, and of course, so we need to be well aligned with our ultrasound beam and RV free wall. So alignment is important, and then inward motion of the RV free wall by shortening of the circumferential fibers, the so-called billows effect. And then it's important the interventricular septal motion in the RV mechanics. So not to consider the septum in the strain evaluation of the right ventricle, I'm not entirely sure this is the right way. Also because the so-called billows effect is extremely important. In pressure overload states, RV contraction is less dependent on the longitudinal shortening, and the relative contribution of the billows function becomes even more relevant. In this movie, we can see an example of the billows effect, where this is the RV free wall, and this is the septum. The septum has to be relatively fixed to have an effective billows effect. But we know that patients with congenital heart disease, very often, they don't have a fixed septum. They have a paradoxical motion of the septum because of surgeries, because of patches, because of pressure overload, because of volume overload. And so I think in the evaluation of the right ventricle in complex patients, we need to assess not only RV free wall, but also the function of the septum. And also in presence of pressure overload, the contraction pattern of the systemic right ventricle will change. This is a very nice study by Erik Petersen. He demonstrated that in normal RV, there is a predominant longitudinal deformation, while circumferential deformation is less. In the normal left ventricle, there is a predominant circumferential deformation with less pronounced longitudinal deformation. Systemic RV behaves more similarly to a left ventricle. Longitudinal strain is reduced while circumferential deformation increases. And this is not only a technical aspect, because we demonstrated that in patients with systemic right ventricle is the circumferential strain that is correlated with exercise capacity rather than longitudinal deformation. But nowadays we can get better information about myocardial deformation, because one of the limits of strain by using 2D speckle tracking is still a load-dependent parameter. Strain is less dependent than ejection fraction, but it still is load-dependent. Recently, we have the possibility to calculate myocardial work. Myocardial work is a technique that incorporates strain and LV pressure. In this regards, we can get rid of the afterload impact on strain. And we recently, together with the Brompton group, performed a multi-center study providing normal values for children in terms of myocardial work as assessed by using strain and LV pressure. We also used this technique in patients with Kawasaki disease, with persistent coronary artery dilatation. Despite the presence of normal ejection fraction as assessed by echo or as confirmed by cardiac MRI, we demonstrated the presence of abnormal myocardial deformation and abnormal myocardial work in Kawasaki disease patient with coronary artery aneurysm. Though it's not considered classically an advanced echo modality, stress echocardiography in congenital heart disease is often overlooked and not so much used. This is related to the fact that traditionally echo in congenital heart disease is based on morphology. We all know very well all the rules of the sequential segmental analysis, but then functional assessment has been often neglected in congenital heart disease. However, with the exponential growth of adult patients with congenital heart disease, it's very clear nowadays that we need an accurate assessment also of ventricular function. And in this regards, stress echo can be of great help. The heart in congenital heart disease, as we all know, has been transformed by surgery. The native anatomy has been modified with patches, valves, intra or extracardiac tubes, stent affecting anatomy and physiology. Stress ECG could not be of great help. When using a conventional stress test, we will have information about chronotropic response, pressure response, double product, ST changes on ECG, but we know that the ECG in this patient is very often abnormal from get-go, arrhythmias, conduction disorders, and functional capacity. However, conventional stress test will not show the heart dynamics during exercise, nor how the valves and the other related structure will function during exercise. Most of patients with congenital heart disease are only symptomatic during exercise, so it's important to perform stress echo, physical stress echo in our patients, because many of them get symptomatic during exercise. And ECG in the vast majority of CHD patients is very specific, even during exercise. By using stress echocardiography, we can obtain hemodynamic and functional assessment of congenital hearts in both children and adults during physiological exercise. The functional information, which can be obtained by studying the stressed heart, can correlate CHD, congenital heart disease findings with residual or sequelae and the type of surgery or intervention that otherwise may be not so clear in the resting echocardiography. This is an example. This is a 16-year-old boy with Fontan. He complains about shortness of breath during exercise. Ventricular function looks very good, but during exercise we notice that the AV valve, where there is a mild regurgitation, during exercise regurgitation becomes severe. And also, we may use exercise tests to try to understand something more about diastolic function in complex patients, like, for instance, Fontan patient. This is one example of Fontan patient with a double inlet left ventricle, and this is the Doppler of the AV valves in basal condition and after leg lifting. After leg lifting, you can see that the E wave went down. There was the appearance of an L wave, and also E prime went down. So we can get additional information by adding this approach. Again, another example, a 16-year-old male with no family history of cardiomyopathy or sudden cardiac death. During an exercise ECG for sports activity, he had a run of 4 beats of wide QRS tachycardia. This is his resting ECG, and he underwent MRI, and according to MRI, was normal, it was just an athlete's heart. We performed a stress echo, and during stress echo, physiologic stress echo, we saw anterior motion of the subvalvular apparatus. We saw also the anterior dislocation of the papillary muscles, generating a dynamic gradient with classic sword shape Doppler envelope reaching more than 4 meters per second. And from the Speckle tracking technique used to assess myocardium, we can now move to the Speckle tracking technique to assess blood flow. Leonardo da Vinci was, for Leonardo da Vinci, there was a universal concept of vortex formation. And for him, the same mechanism should occur inside the body and inside the heart. He thought, looking at nature, that vortex are everywhere where is water. So he understood that vortex formation should have a role also for the cardiocirculatory system of the human being. And those are his drawings, where he firstly demonstrated the vortex formation in the sinus of Valsalva, and he reached this concept without any imaging technique, but just with looking at nature. And indeed, blood flow in the human body exists in 3 states: laminar flow, turbulent flow, and vortex. So at the level of the mitral valve, the laminar flow is converted in vortices during LV diastole. So the shifting from the flow from the left atrium to the left ventricle creates vortex, and this vortex is typically localized between the anterior leaflet of mitral valve and interventricular septum in the outflow portion. It's a way for that nature used to preserve kinetic energy and to reduce pressure. Unfortunately, with conventional echo technique, we cannot study vortex formation because Doppler, as we all know, is an angle-dependent technique and also is limited by aliasing velocity. So the velocity scale is limited by the pulse repetition frequency, the Lindquist limit. Nowadays, there are several techniques trying to better understand blood flow imaging. Some of them will need the use of contrast agents. Some others will rely on assumption from color Doppler. But there is another option that has been recently proposed called blood speckle imaging. And this approach is based on tracking speckles generated by moving blood cells from one frame to the next one using the best match search algorithm. In this way, we can assess blood velocity vectors without injection of contrast agents and without any mathematical assumption based on conventional color Doppler. However, this approach can only be done in children because we need a probe with a very high frequency. We need a very, very high frame rate, or can be obtained by using transesophageal probe, because we need to obtain a very high frame rate. And our group used this technique in different congenital heart disease. Here you can see the vortex formation. You can see the vortex formation just between the anterior mitral valve leaflet and the LVOT. And this can be applied not only to the left ventricle, but also to the right ventricle, or also to assess the aortic arch. Many examples demonstrated the presence of bicuspid aortic valve, how the flow can change in a significant way. Nowadays, we can study blood flow at the bed of our patient without using, in a very cheap way, without using any contrast agent, without using any color Doppler assumption. Of course, the limit of this technique is that it's not quantitative. At the moment, we only have a software that can display patterns, but unfortunately, we don't have yet quantitative software, so we cannot measure size of vortex, duration of vortex, and parameters like this. So all good for echocardiography, yes, but there are, of course, and we all know, there are, of course, important limitations. First of all, operator dependency, and also all the analysis. We can use the most advanced software we have in our hands, but if the image quality is poor, we will just multiply errors. So it's extremely important to get good image quality. And the limit of echo is, as I said already, is the low signal to noise contrast ratio. So what will be the future perspective? Artificial intelligence is very important in the field of imaging and in the field of diagnostic. And probably the technique that will benefit the most from artificial intelligence will be echocardiography, because echocardiography is technique more operator dependent. In this way, applying artificial intelligence on echocardiography, we can improve, and we can improve a lot the reproducibility, because we can improve the image, we can standardize image acquisition, we can obtain a standardized segmentation. The artificial intelligence software can do a quality check, can reduce in a significant way the number of human interaction, which are extremely important during measurements. Every day for each patient we do around 250 clicks for a single study. And this, of course, is a tremendous source of variability. Using artificial intelligence, we may get rid of operator dependency. We can automatically compare the current study with previous stored studies, and in the future, artificial intelligence may provide us diagnostic probabilities. In this review, it's been suggested how artificial intelligence can help echocardiography. We only use very few data, but for a computer, the 2D grayscale, only the 2D grayscale image is a number of pixels, and each pixel is a number. So they can recognize pattern and try to reach a diagnosis following this pattern. So there are a lot of information besides what we see by our eyes. And commonly, a cardiologist or anyway a physician reach a diagnosis focusing on on several parameters, but of course computers can use many more parameters that we can and can implement diagnosis. So this is an example of how artificial intelligence is already in our hand and how improve our quality of life in performing studies. Once we acquire a clip with a 4-chamber view, we just need to click one button, automatic analysis, and the software will identify and diastole and systole, will do the tracking, and will measure volumes, and will provide us volumes, ejection fraction, and global longitudinal strain without zero human interaction. And so getting the reproducibility very high. This is for the 2D, but also in 3D nowadays, from a complete 3D datasets, we can obtain with a very few clicks with a semi-automatic analysis, we can obtain volumes, mass, ejection fraction, but also global longitudinal strain, circumferential strain, and radial strain. Or, as we know, we can also, without any interaction, we can obtain the so-called dynamic heart model, which will provide us diastolic volumes, systolic 3D, diastolic volumes, 3D systolic volumes, ejection fraction, once again, strain for the right ventricle, also the TAPSE, and the fractional area change. All this will reduce a lot of the time and the quality of our acquisition with an excellent test, retest reproducibility. And as I stated in the previous slides, I think for the follow-up of our patient is very important the longitudinal assessment of the parameters rather than a single cutoff value. So reproducibility will improve a lot our diagnostic accuracy. So, and with this I come to my conclusion. At the turn of the 20th century, complex congenital heart disease was uniformly fatal, with no meaningful treatment options. The last 50 years have witnessed a birth and exponential growth of a CHD population. But more importantly, the next 50 years will likely see more revolutionary innovation in this field. And I would like to thank all the friends in Padova and at the Brompton, where contributed significantly to the studies I presented to your attention. Thank you very much.
Thank you very much, Giovanni, for your excellent overview and journey through the different techniques in imaging congenital heart disease patients or patients with cardiomyopathies. There are two questions in the chat. Omran has a question. My question to you is the difference between cardiac mechanics in pediatric and adults, especially pattern of cardiac twist. Is there any twist in normal pediatric heart, or heart will learn how to twist in later age? So he has a question regarding the twist between the pediatric and adult population?
Okay.
Between the adults and the young adults or pediatric population?
So thank you very much for the question. I'm so sorry that my camera is not working. What I want to say, yes, I mean, in terms of twist, we found more or less in pediatric population similar values, not so big difference compared to adults. Of course, there might be changes, especially in the first few weeks of life, in terms of twist of the left ventricle. But on this, I don't have personal data.
Okay. And then Dr. Fernandez, one of our agency fellows, has also a question. How many FPS do you need to do blood flow speckle tracking?
How many frames?
How many FPS? Yeah.
Yeah, sorry, frames per second. Yes, sorry, because so yes, with the current technique, we need a frame rate around more than 250, around 400 to 500 frames per second. This can only be achieved with pediatric probes in pediatric patients. In reality, the software uses a even higher frame rate, but this cannot be displayed. Otherwise, the 2D image quality will be deteriorated. And this is the reason why we can use this technique only for children or in the adult patient by using transesophageal echocardiography.
Okay. Dr. Manuel Alvarez Gaviria has a question. So thank you very much for the excellent presentation. What should we consider when using echocardiography as a guide in interventions in these patients?
Say it again, sorry, what should be considered?
What should we consider when using echocardiography as a guide in interventions in these patients?
So I think echocardiography has a major role in guiding interventions, especially transesophageal echocardiography, and we all use transesophageal echo in guiding procedures like ASD closure or VSD closure. And also, while I was at Brompton, we use a lot of echo for PTA closure, especially in premature babies. So that's very important. And also the three-dimensional echocardiography for structure like the mitral valve, when we think on procedures like mitral valve clip, is extremely important. So in this regards, I think that the information that we get with transesophageal echo during the procedures is extremely helpful and it's extremely important. And of course, also in the theater, when we help our surgeon in decision-making, transesophageal echocardiography is probably the best technique we have to answer many of the questions.
I have a question. So, application of these advanced techniques, for instance, speckle tracking in the right ventricle is much more challenging in the adult population because of technical challenges, because the echo window is not as good as it is in the pediatric population. There are other challenges, and sometimes the right ventricle can be very difficult to be imaged and visualized in the adult population. So speckle tracking, I think, has some limitations in adults with congenital heart disease, and I'm always concerned about the reproducibility of the measurements which we obtain, and that's the key when we want to have a longitudinal data on the reproducibility. And you also mentioned that's very important. So we need to rely on the numbers we get. So thank you very much. tracking the RV in the adult population, do you see this as just a research tool? Is it just a research tool, or does it have any clinical application during our routine clinical practice?
So thank you very much for this question. You are absolutely right. Sometimes it's difficult to image the right ventricle in adult patients. And this is a problem. This is a problem of echocardiography. We can do whatever we want. We can have the best parameters, functionally speaking, and also in terms of prognosis, but everything starts from 2D image quality. So 2D image quality is of paramount importance. If we don't have good 2D image quality, adding softwares will just create confusion. I fully agree with you. So yes, first of all, we need good image quality. We have to say that in the last years, the companies are working a lot on this. Probably we don't realize, but the image quality that we can get nowadays is much better than that we obtained 10 years ago. But again, we still need further improvements. And the adult patient with congenital heart disease may be very tough to be assessed because previous surgeries, chest deformities, so it's difficult to get a nice window. So that's absolutely right. And if you don't have a nice window, you can, I will not use advanced software because in my opinion, just you will add noise rather than information. But if you have a good window, then I think you should do the assessment of RV by using strain, and this can provide you prognostic values. Nowadays, with the new software and with the automatic intelligence, the number of clicks and the number of human interactions is very minimal, and so the reproducibility is much better. So I think that rather than to base ourselves on a cutoff value, we should think about changes over time in the single patients. Reproducibility is an issue for the echo, and this is why I think artificial intelligence may come to rescue and help echocardiography. Probably echocardiography will be the technique that will benefit the most from artificial intelligence, because with this approach we may significantly improve reproducibility, and this is a key factor. Yes.
That's just another question regarding Speckle tracking and strain. So in complex congenital heart disease patients, we have normal values for patients with a normal heart or in patients without congenital heart defect, but all these reference values obtained in patients with a biventricular circulation and normal hearts, no structural heart disease, all these reference values do not apply to patients with complex congenital heart disease, for instance, patients with subaortic RVs or even patients with a univentricular heart. And I think it's more important to have a longitudinal number, which again need to be reproducible, longitudinal numbers on each individual patient.
I cannot agree more with you. I think we should not rely on cutoff values for our complex population because each patient is unique, and this is extremely true for the ACHD patient. So rather than base our decision on a magic number which does not exist, we should rely on longitudinal assessment of the same patient and the same parameters. And if we see a significant change in that parameters, then this should raise a red flag. Of course, this implies that our reproducibility should be good.
Yeah, that's why I always say longitudinal data are more important than just a single snapshot.
Absolutely agree.
There's another question from Dr. Jung Savli. So, LV strain ball eyes is reliable and crucial in congenital heart disease. That's his question. And he says that he uses it infrequently. And he asks you about more detailed about LV strain?
So I have to say that I use LV strain almost routinely in my patient, provide that we get a good 2D image quality. Bullseye, it's something fast, eye-catching, and simple. But I will also recommend to, instead of looking at the numbers, to look at the shape of the curves. So rather than to rely on the bullseye, to check the curves of each wall and see, first of all, if the numbers that we get are reliable. Of course, bullseye is easy and can provide a quick overview of what is going on, but I always prefer to have a look on the shape of the curves rather than the peak value and the isolated value.
Okay, then Dr. John Smith has a question. So thank you very much for the excellent talk. How do you see the implementation of strain in congenital heart disease? Is this feasible in clinical practice? So again, is it strain more a research tool, or can we use it in daily clinical practice for the decision making?
Yeah, I think that nowadays, I mean, there are several studies demonstrating that global longitudinal strain, at least global longitudinal strain, has a prognostic value, that global longitudinal strain can get worse earlier than ejection fraction. So it has a clinical value, and sometimes, when we are there is a borderline situation and we are not sure about ventricular function, I will always check the global longitudinal strain. In clinical practice, with the current software, is not time consuming. As I showed you in the previous slides, nowadays we just need to acquire 4-chamber view, 2-chamber view, and 3-chamber view, and the software will get ejection fraction, volumes, and GLS. So, in my opinion, with the top gamma machine available nowadays, just take a few seconds. So it's completely integrated in the clinical practice.
Okay, so thank you so much, Dr.
Thank you.
Giovanni Di Salvo, for your excellent overview and journey through this advanced technique in echocardiographic imaging. There's still a lot of work to do. Some of these techniques are still a research tool and are not applied to our clinical practice, but this may change in the next 10 or 15 years. So thank you so much.
Thank you very much. Thank you very much.
All the attendees for joining us at our Toronto International ACHD rounds on a Friday morning. These are our last rounds before the summer break. So there will be a break in July and in August, and we will be back in early September 2022. I just remind you, please complete the survey. There's a link for a Survey Monkey. And this is important for you because these rounds are accredited by the Royal College of Physicians and Surgeons of Canada, and you can claim CMEs at the end of the year. So please complete the survey. So I wish you a wonderful summer, a lot of fun, excitement, and a lot of adventures during the summertime. And I'm looking forward to seeing you back in September. Have a very nice summer. Bye-bye.
Bye-bye.